Good evening, everyone, and I'm so grateful to Dr. Jain and Dr. Goel for allowing me to talk on such an important topic. It is one of the topic I'm quite passionate about. I have worked in many ICUs and also aspire to make our ICUs as good as ICUs of developed countries where the incidence of VAP is less than 0.1%, which is the dream. In our ICUs, the incidence, even the studies in the study condition, is more than 7.5%. So it is a very important topic. It has long standing and very important issues attached to it. Let me take you through this presentation. As so Ages ago, Florence Nightingale, she was one of the most respected nurses in her time, and even now said that most important principle, which is the first requirement of hospital, is to do sick no harm. I would say that in a hospital, the biggest harm you can do to sick is to make them sicker, and infections, hospital acquired ones specifically, are those which will make sick people sicker. Some this that patient came to hospital in a good state. He came walking. Now he's in such a terrible state. A lot of it is contributed by hospital acquired infection, and everybody of us who run a hospital or practice in a hospital aspire to make our hospital infection free, make our ICU infection free, zero ICU acquired in all work toward it. So this is a typical ICU environment, as you can see, and there are a lot of factors in an ICU which can lead to ICU acquired infection, like a urinary catheter, central lines, a patient who is lying on a bed, he's on ventilator, which leads to increase in secretions. He has several lines in C2. On the top of it, he's getting some antibiotics, which will lead to antibiotic resistance and which will lead to hospital acquired infection in turn. So these are common type of VAP, ventilator associated pneumonia, catheter related bloodstream infection, and catheter associated urinary tract infection. Other than that, there are also surgical site infection, but I'm not covering the surgical ICU infection. So why are we even talking about ICU acquired infection? 15 to 25% of ICU patients suffer from ICU acquired infection. Most common ICU acquired infection is ventilator associated pneumonia. Other are CLBSI and CAUTI. So risk factor are catheter, neurological dysfunction. That means a typical profile of any ICU patient. And microbiology is usually multi-resistant drug, drug resistant organism. And we are not left with any antibiotic to give patients. We are exhausted our armamentarium, and infections are still progressing. So these are this is how difficult ICU acquired infections are to treat. And this is how difficult acquired infection in India is very high. It ranges from 10 to 30%. And these burden of these infections is substantial. It contributes to morbidity for the patient, mortality of the patient, and not less, but healthcare cost also, which is a concern for everybody, starting from patient to the doctor to the hospital, whether it is public hospital or private setup. Then contributing factors are crowding in ICU. Looking at our population, overcrowding in ICU is always going to be inadequate infections and rise of antibiotic resistance. So this was a huge study which was done in India, which gave us this data about cost of nosocomial or hospital infection in tertiary care.
Ma'am, audio is
As a
not
with
proper.
uninfected bill.
Audio is somehow problematic.
I'm sure it is going to be better now. So let me discuss this study, which was done in a tertiary care hospital in Western India, and they directly showed that the cost of infected group was 3 times the cost of uninfected group, which is a huge difference. And it's about 4 times than average patient. And length of hospital stay was significantly higher in people who have increased cost. So not only it affects patient morbidity and mortality, hospital stay in our ICUs. So just look at this graph and you will know that what is the incurred by various. So there's another indic which was published in Indian Journal of Critical Care Medicine, which says that infection rates are as high as 10.4 per thousand ventilator days for VAP and 7.92 per thousand catheter days for CLABSI. Most common organism which causes these hospital-acquired infection are escape organism, that is Enterococcus faecium, Staphylococcus aureus, Pseudomonas aeruginosa, Acinetobacter baumannii, E. coli, and Klebsiella. So if you will even look at epidemiology of your own ICUs or in your own hospital, it's the most common organism keep on varying between these escape organism. Only thing is that their antibiotic resistant profile changes over a period of time. Whichever antibiotic you're using more often in your hospital over a period of time, these organisms develop resistance to those antibiotics. So most common organisms still in India are gram-negative organisms, which are resistant to almost all antibiotics in ICU, including beta-lactams, fluoroquinolone, macrolides, and cephalosporin, which are showing varied percentage of resistance. Let's look at the resistance data. So if you look at this data, the side 40 had 100% resistance to antibiotic. In case of acinism these days in our ICU, second only to Klebsiella, which is emerging as the most common organism. So these escape organisms are the most common organism for any hospital-acquired or ICU-acquired infection. And out of 133,445 patient days and 40,533 ventilator days, 261 VAP events were recorded in this study, which was done in which was published in Lancet, the most important journal of medicine. Acinetobacter followed closely by Klebsiella species, and Pseudomonas was also not far behind. So what are the risk factors for ICU-acquired infection? Prolonged ICU stay. With each day in ICU, most of the study says that it increased at least by 1.34% per extra day in ICU, which is a huge number. Underlying medical condition, patients who have diabetes or other chronic illness like COPD or malignancies are more susceptible to infection. As many invasive devices are there, more are the chances of infection, which will include endotracheal tubes, urinary catheters, central venous catheter, and the entry point of these tubes and catheter become entry point for pathogen. Not least, immunocompromised patients with weakened immune system are unable to fight infection, and these also lead to ICU-acquired increase. They also are at increased risk of ICU-acquired infection, and also they potentiate other patients around them to increase risk of MDR. So all of us want zero one size fit all. Every ICU is different, every place is different, every country is different, patient profile is different. Even in same hospital, different ICU, like a onco ICU is different, a cardiac ICU is different. So we have to devise strategies according to our ICU. From most infections are unavoidable, some preventable, to all infections are potentially preventable unless proven otherwise. So let's see how do we achieve that. So let's take infection one by one, and all the infections all the infections bring certain bundles. For VAP, hand hygiene is important all across. and you should use both hand washing as well as hand sanitizer. Whenever your hands are soiled by secretion, always resort to hand washing. A regular oral care, including brushing of teeth and flossing, help reduce bacterial load in the mouth. Head of the bed elevation by 30 to 45 degrees reduces the risk of aspiration, and then implementing a VAP bundle that include daily sedation interruption. That means that if your patient is on ventilator and sedated and paralyzed, you should practice daily sedation interruption for that patient. Use peptic ulcer prophylaxis wherever required. Use DVT prophylaxis for most patients in ICU, at least in surgical ICUs. All these strategies have shown to decrease VAP rates. So, whenever you are aspiring to prevent ventilator-associated pneumonia non-pharmacologically, start with strategies which have certain evidence and strictly adhere to those strategies. First one, foremost being that when to put a patient off mechanical ventilator and wean patient off mechanical ventilator and wean him as soon as possible. Till then, follow hand hygiene compliance and semi-recumbent body position. Some evidence is also for physical. After that, you should aspire to improve yourself and establish a surveillance system, which gives you a definite definition of hospital-acquired infection. You will have a infection control team and incorporate the feedback given by infection control team, which should include everybody. Should include treating physician, should include a microbiologist, should include a pharmacologist, should include nursing staff, should also include ground staff, because you want to incorporate feedback from everybody, and everybody is important part of the team. Then develop VAP prevention bundle, which adapt to your local condition, which you can follow in your local ICU, and then become excellent when you start using endotracheal tube with subglottic secretion drainage, and become a VAP prevention hero. So all these require interprofessional team training, reminders, checklist, and regular feedback to the team. So a cooperation between facility as well as having good equipment and dedicated staff member is must to start and become excellent. You also need additional resources like SOPs, infection control team. I think I would elaborate a little bit on SOP. See, there have been many studies whether your treatment should be physician guided or it should be SOP guided. I feel that physician guided management becomes very chaotic. So if you have SOP, which can be modified according to patient and can individualize according to patient, they can work best and they can help you to prevent any kind of ICU-acquired infection. There should be a very transport reporting system. Nobody should feel that they are being held culprit, and people should only, the task should only to improve the team and never to punish anybody. So there should be incentive, but positive incentive, not negative incentive. Then if you have a lot of negative incentive, it leads to hiding of the problems. You should have proper teaching material, and they should be available all over your ICU or all over your hospital, and there should be a point person whom people can talk to whenever there is a problem. So for CRBSI, again, there are and then there are maintenance bundle. For insertion bundle, for maintenance bundle, both of them, hand hygiene is the most important part. And cleaning the area with 2% chlorhexidine is must. Choose an optimal site for central venous catheter insertion and try and avoid femoral vein where a checklist during insertion. So when I started doing a central line insertion, for every central line, I used to go back to my checklist, and it helped me a lot in long run. So if we have a checklist in our ICU, which we can follow, and we can give a senior consultant or a junior doctor while inserting central venous catheter, then it can take you long way. And there should be a communication training in the sense that doctor can also be stopped by nursing when they by doctor if they are not following the procedure properly, and there should not be any ego in that. There should be such communication training that every suggestion is welcome. When you are very important for nursing proper and before assessing or changing line. Always use aseptic technique when assessing or changing line. Change tubing in a standardized way according to your SOP, and daily review of lines is necessary. So you can see the gap which was covered when and huge gap which was covered. If you see the black line and the blue line, you can see that how much gap was there in decreasing the rate of infection, which decreased from about 13-14% to 4%, and then it also touched zero at some point in time. So AIMS infection control reports 2021 decrease in CLABSI rates by 55% after implementation of bundle. And this is not rocket science. These bundles, all of us know. Checklist every time, then you will actually follow the bundle, and then checklist is become a second habit. It is in your mind. You don't even have to tick a physical checklist. It is you're ticking it in your brain, and it can decrease CRBSI rate by as much as 55%, which is a huge number. So this is the study which was published in Journal of Intensive Care Medicine, and this was a meta-analysis which include 36 studies with 116,873 participants. And most reported component of ventilator bundle was head of bed elevation, which is such a simple thing, followed by oral care. Reduction in VAP episode, significant reduction in VAP episode was observed in those receiving ventilator bundle as compared to non-care bundle. And implementation of care bundles decrease ICU stay. It also decreased length of hospital stay. It decreased direct and indirect both kind of cost for hospital, ICU, as well as patient. So implementation of mechanical ventilation resulting in lower costs for patient as well as hospital. So these are the strategy which you can follow to prevent CRBSI. Hand hygiene, sterile technique for VAP, for catheter-associated urinary tract infection. But there is something beyond the bundle. That was a start, and that was improved. Now we are going towards excellence. So when you move toward with some kind of clinical epidemiology, which should find the root cause of each and every hospital-acquired infection which happens in your hospital, and then re-education, re-emphasis on central removal as well as maintenance of central line, root cause analysis, investigating what has caused CRBSI in this particular patient, and then use of PCR techniques to confirm environmental contamination, which I will touch little bit at the end of the presentation. So for CAUTI, same bundles, same thing. Use only indwelling catheter when it is necessary. Otherwise, try to use condom catheter, try to use diapers, try to encourage patient to self-void. You always use a sterile insertion technique. Catheter care is mandatory. Maintain a closed urinary drainage system. Secure catheter to bag and keep the drainage bag below the level of bladder all the time. Check for leaks, check for kink, check for blockage in catheter and drainage system. Very simple, but you still need a checklist to do it every day. So let's go beyond bundle, addressing the challenges. So we have these three evidence-based strategies which can actually address hospital-acquired infection, and these are still challenging. Even best of the nurses or best of the doctor at some point in time forget about hand hygiene. So I would insist that people who are in charge of ICU should lead by example and should always follow hand hygiene. When you enter your ICU, you should enter while using alcohol sanitizer or while washing your hand, so that your team is always motivated to use hand hygiene or checking and re-educating the people. Then environmental cleaning and disinfection is must. It should not be like home cleaning. A hospital require more detailed environmental cleaning and disinfection. And of course, antimicrobial stewardship, which will prevent many multi-drug resistant hospital-acquired infection. So hand hygiene compliance require education, then reminders, then auditing. Maybe we are actually educating our staff, nurses, doctor, support staff, even relatives of the patients for hand hygiene. Then there should be visible reminder. You see, if you have those poster of hand hygiene at every station, wherever you have alcohol sanitizer, it will make such a difference. Now, if you see it, you will do it, and it will reinforce your hand hygiene practices. Then audit. If every is following hand hygiene, if your patient develop ICU acquired infection, then audit all the people who have been involved in patient care and see if they are adherent to basic hand hygiene. You should do a high level disinfection and sterilization wherever in a good and safe infection free environment. And antibiotic stewardship is a very big topic in itself, but it is must for any hospital if they want to minimize their ICU-acquired infection, if they want people not to develop multi-drug resistant organisms infection. So a baseline assessment, then a proper antibiotic selection, then dosage optimization. See, a lot of us talk about that we should be using adequate antibiotic, we should be using this antibiotic, we should be using that antibiotic. Very, very important. All antibiotics should be given in adequate recommended doses, and then also they should be properly managed according to kidney function test, according to liver function test, and then hospitals we see that once a patient is started on antibiotic till the patient is out of hospital, antibiotics goes on and on and on. Last I saw same antibiotic being given to that patient, to a patient for 50 days. Same antibiotic was doing for that patient for 50 days, and it is a top antibiotic what we have now. And we have to understand even the antibiotic which are newest have narrow spectrum. So if we are giving antibiotic for certain organism, then maybe after some time, even if this patient have continuing infection, may not have that organism, may have developed different organism. So you will need to change antibiotics. So you need to keep on sending your culture whenever you suspect infection. Keep on doing gram staining whenever you suspect infection, and then change the antibiotics accordingly. Also rotate your antibiotics. Otherwise, if you keep using same antibiotic for 50 days, then people will develop breakthrough infection. So implementing antimicrobial stewardship program is critical for any hospital, how small that hospital may be. Who can be microbiologist of the hospital? So then comes surveillance and monitoring of ICU-acquired infection. You should collect the data, analyze, intervene, and then evaluate your interventions also. It is very important to engage all healthcare workers. I must insist that as physicians, as doctor, we can do as much. So if you make people who are directly involved in patient care, they will and make them responsible for it. They will make them responsible for it. They will be very happy to take initiative and do some education, do some communication part of, and feedback also. So engage all level of healthcare worker as well as patients in your infection prevention program. So to go towards zero in ICU-acquired infection, we need 100% compliance. For 100% compliance, we need everything: education, communication, monitoring, feedback, incorporation of feedback, and then feedback on feedback. So major barriers. This study what are the barrier towards infection control. You must retain your nursing staff, because if you are not able to retain your nursing staff, then you will spend a lot of time training a new staff, lot of time for that staff to imbibe whatever you need from your staff, or lack of infection control in ICU. Then language competency, having heavy clinical workload. If one nurse is looking after 4 patients in ICU and 2 of them are ventilated, I can imagine that she is transmitting infection from one patient to another, because she does not have time to even sanitize her hands in between. And doing those bundles and ticking her checklist is a far cry. She will not be able to do that. So it is very important that staff should have limited clinical workload, and you should have a well-developed infection control team and institutional climate that prioritize infection control. So there is still hope towards attaining zero infection control ICU in India with multidisciplinary approach, with surveillance, with continuous quality improvement, and in a hand washing at all time. We can go towards, this can be a start towards zero ICU-acquired infection in India. So this is our objective, to reduce incidence of hospital-acquired infection in ICU. Primary drivers can be providing best possible care to patient, develop highly effective multidisciplinary team, and integrate patient and family members to take decision in making care team. Then following your bundles, CRBSI bundle, VAP prevention bundle, CAUTI insertion and maintenance bundle, the environment of mutual collaboration and free communication. Develop a culture of safety. The culture of safety is very important. See, if our staff thinks that they are going to be punished for whatever mistakes they have made, then those mistakes would never be reported. We will never get feedback on the system. So if we have a positive reinforcement technique and positive culture, then it would be culture of safety, and involve patient and their relative wherever possible in daily care planning. A transparent communication between patient and family is very important. So when I'm talking about this zero infection rate, or zero is a very risky business for hospital-acquired infection. This is a very practical thing which was studied by, which was an editorial which was published in Clinical Infectious Disease, which says that infection develop on several factors. It depends upon patient's condition. It also depends upon how severe the disease is. Also depends upon length of hospital stay. It depends upon whether patient is immunocompromised. There should be zero ICU-acquired infection. It would be very difficult to explain to patient's relative or patient why the patient developed ICU-acquired infection. Then comes the question of insurance companies. It is acquired infection in US. Insurance company punishes the hospital by not giving them dues and all. So talking about zero concept of hospital-acquired, the risk of hospital-acquired infection, and not talk too much about zero ICU-acquired infection. And we should not say, because we don't really understand that why some patients develop infection, why other do not develop healthcare infection in the same setup. So zero is still a very utopian concept, but very low hospital-acquired infection is doable. So then taking it to another level, we can leverage technology to enhance ICU control, infection control, which includes smart sensors, robotic disinfection, and automatic hand washing station. See, I feel that automated hand washing stations are very doable. They are very simple, and they actually can follow. You can actually follow hand hygiene if you have automated hand washing. So are resistant to many antibiotics, multiple antibiotics, and make infection hard to treat. And incidence is increasing globally because of overuse of antibiotic, poor infection control, and also increased travel. Village or in my country, even we are traveling and we are getting a lot of infection from all over the world. Taking an example of HIV or COVID even. So if you will look at summary of antibiotic resistance timeline, it is touted that 10 million antimicrobial resistant related death will be there every year. In 2017, a clinical Klebsiella pneumoniae strain resistant to all commercial antibiotics was discovered. Resistance as antibiotic enters into cell of bacteria. Alteration of drug target is key feature for development of antibiotics. But if we look at newer antibiotics, I think last new antibiotic was in 2020 for that same antibiotic packaged in new bottle like BLI. Beta-lactam antibiotic with beta-lactam inhibitors like tazobactam, sulbactam, so on and so forth. So not really any new antibiotic is developed after 2020. So there is limited novel antibiotic discovery. There is a lot of antibiotic resistant development, and antibiotic which are new have limited spectrum of antibiotic. The most popular antibiotic these days is Jevicefta and Astronam combination. Let me tell that it has very limited spectrum of activity. We are giving at the outset our patient Jevicefta Astronam. We are doing great disservice to these patients because it is not even covering escape organism. So we should be very, very wise in choosing our antibiotic. Should not choose limited spectrum antibiotic for the patient who may have any organism, and should de-escalate antibiotic as soon as we discover the organism. Antibiotic will require complex clinical trial, and there is going to be a need of combination therapy. So what we can do other than development of new antibiotics? Will novel antibiotics win war against MDROs? Novel antibiotics will never win war against MDROs. Drug-resistant organisms are very smart. As soon as you develop a new antibiotic, within a year they develop resistance to those antibiotics. So our powerful new mechanism to bypass resistance, but bacteria will continue to evolve. So why not diagnose these organisms early so that you can give adequate antibiotic, decrease the incidence of multi-drug resistant organisms, and decrease the incidence of antimicrobial associated adverse effect. So only 7.6% of 17,435 patients who are hospitalized with CAP got microbiological diagnosis. So about 10 days or 15 days back, I was reviewing community-acquired pneumonia data for one of the presentation and found that hardly 10%, even less than 10% get microbiological diagnosis in CAP. So they often get multiple antimicrobial. And some people even get successive dose of antibiotics when actually there was no infection. Sometimes people just have symptoms because of sequelae of infection, like your CAP patient may have cough for a longer period of time, but he does not have actually CAP. So most CAP does not require more than 7 days of IV antibiotics or oral antibiotics, and this lead intense pressure for patient microbiota and encourages development of antibiotic resistance. Supposedly, we are able to diagnose these organisms, then we can give proper antibiotic, can give shorter course development of antibiotic resistance. So these are the new technique which are available now: rapid molecular diagnostic test, point of care testing, and genomic sequencing, which can help us to diagnose organism early. And I'm sure that most of us are very well aware of rapid identification of MDROs and what we call biofire in a normal language is are readily available, though quite expensive. But see, if you are giving 3 antibiotics, a per day antibiotic cost will be more than cost of biofire. I think it is worth exploring. So try to diagnose your patient early by using all these methods: nasopharyngeal swab for PCR, and atypical sputum and endotracheal aspirate. Wherever possible, try and use bronchial alveolar lavage. For GI, also similar investigations are available. So try to isolate the organism and treat the organism wherever is possible. So when combined with, was shown to lead earlier de-escalation in greater than 50% of the patients. So integrating novel diagnostic and clinical practice is must. A rapid pathogen identification can lead to tailored antibiotic therapy and support antibiotic stewardship their own, and also follow all the bundles to prevent hospital-acquired infection. So future outlook is for integrated approach to combat antimicrobial, which will include novel antibiotic development, which will include non-pharmacological prevention strategies, which can lead to comprehensive infection control, and also not but least antibiotic stewardship initiative. So our future is good if we are able to control infection by diagnosing them early, by treating them properly, by preventing further infection, and also leading to low hospital cost and less morbidity for patients as well as doctors. Thank you so much. This is all. I'm open to any questions.
Thank you, ma'am, for a wonderful lecture. Though there was some challenge with your audio, but still it was a wonderful lecture, nicely covered. And what I could gather from your talk is hand hygiene is of utmost importance. Team approach for
Absolutely.
infection control is really, really wonderful, and it is the only way we can try to get zero hospital acquired infections. And antimicrobial stewardship should be taught to every stakeholder in the hospital. So these 3 points are the most important points which I could gather. uh, there is one question from me, ma'am.
Sir,
How to
I will
prevent the
also
biofilm
I will also
formation?
want to point out the last part of the lecture. Using novel diagnostic techniques to diagnose is the future for
Yes, ma'am.
infection control and treating patients properly.
Because empirical antibiotic therapy should not be continued without doing the microbiological diagnosis. Because whenever we are
Absolutely.
using empirical antibiotic therapy, we are using basically broad spectrum antibiotics. The antibiotic should always be tapered to the narrowest spectrum antibiotic after the microbiology diagnosis. And newer techniques like biofire or other rapid molecular techniques are really, really wonderful, and they are really important to know the susceptibility pattern of all the bacteria. So it is definitely it is very, very important. But definitely the cost is a hindrance in small hospitals. But definitely if we do the audit of cost versus hospital stay and cost of antibiotics, then definitely the cost of microbiological studies, definitely it is much, much lesser.
Average biofire will cost you somewhere around 12,000 for
Yes.
respiratory secretions. And
Yes.
one day antibiotic cost can be as prohibitive as 20,000, not including hospital stay cost, not, not including other costs.
Ma'am, there was one question from me. How to prevent the formation of biofilm? Because biofilm is the most difficult entity to treat in our ICUs. And uh, could you throw some light on this?
So, preventing the formation of biofilm is very difficult, but translating that biofilm into hospital-acquired infection is something which we can prevent by following simple methods of not disturbing the biofilm. So if you are able to take care, if you are able to even cover your catheter sites properly with proper dressings and change your dressing frequently, even that can prevent biofilm formation and also decrease the incidence of invasive infection from biofilms. And of course, our usual hand hygiene practice can also help to prevent biofilms.
Yes, ma'am. Any questions from any other participant? Dr. Rizul, do you have any question?
Hello, sir.
Yes. Do you have any questions?
No, sir. Biofilm can be means we can prevent biofilm by using means routine practices like not hand hygiene and other things which add to the film. By means routine practices can be done.
Definitely.
Like not adding too much of the outside sources to the patient, to the cat mouth and other places which can lead to biofilm formation. Yes, ma'am can add on this.
A lot of things which have been practiced to lines or silver coated center lines, but none of them, other than using the usual practice, have found to be effective in preventing biofilm formation.
Okay.
Any other comment or questions?
Dr. Neetu has covered the topic in a very excellent way, and definitely a simple thing, the hand hygiene, if it is followed in our practice, I think it can prevent a lot of infections, as usual the other things also. But this is the single most thing which not only in the ICU, even our NICUs also, this is supposed to be the best practice and which can decrease the infection a lot. So really very good deliberation by Dr. Neetu. And on behalf of IMA Haryana, we are thankful to Dr. Neetu and to all the participants and Dr. Pawan Goel in specific.
Thank you, sir. Thank you. Thank you, ma'am. And thank you.